You're listening to Pedia Pain Focus, episode number 55. We're talking about neuropathic pain amongst children. So stay tuned.
Pedia Pain Focus.
You're listening to Pedia Pain Focus, brought to you by Proactive Pain Solutions. Pedia Pain Focus highlights pediatric pain information and provides tools and resources for all healthcare professionals taking care of children dealing with pain. Here's your host, Dr. Anjana Kundu.
Hello, ladies and gentlemen, and welcome to Pedia Pain Focus, episode number 55. Today, my guest is Dr. Alyssa LaBelle from Boston Children's Hospital. She's the co-director of Headache Program and a senior associate in pain medicine, the Department of Anesthesiology, Critical Care, and Pain Medicine. She's also the associate professor of anesthesia at Harvard Medical School. Dr. LaBelle was one of my attendings when I trained as a fellow so many years ago now. And she is actually unique with her qualifications in that she's trained both in pediatric neurology and in pain medicine. So she's quite a rare combination and the perfect person to speak on this topic with greatest authority. And given her extensive knowledge around neurology, especially pediatric neurology, and then her subsequent training in interventional pain medicine, she is an amazing person who has such a logical approach to when it is appropriate for children to have interventional pain procedures or interventions as opposed to non-interventional measures. So you are going to love everything that she has to share with us today. During her earlier career, Dr. LaBelle chose to devote her clinical practice primarily to the treatment of patients with significant pain, both for adults and children with cancer especially, but then she specifically focused on pediatric patients and more so for neuropathic pain. But currently, she is at Boston Children's and where she has been for nearly 2 decades now. And since then, she has focused her practice more increasingly on chronic headaches. She has written extensively and lectured both nationally and internationally on the mechanisms and treatment of pediatric headaches, as well as the neuropathic pain. She has established and directs a multidisciplinary pain management program for children with chronic headache and is recognized as the authority in the area of pediatric and young adult headaches as well as neuropathic pain. So let me invite her to the stage. Let's welcome Dr. Alyssa LaBelle. Dr. LaBelle, thank you so much for coming to Pedia Pain Focus and giving me this amazing time to pick your brains. So long after my fellowship.
Thank you for your kind invitation. We all remember you very fondly at the Pediatric Pain Training Program over at Boston Children's.
Oh, thank you. I remember my time very fondly there as well. It was so great. And I think the highlight was having you also join the team while I was there. And what a unique opportunity I had to train with you. So that was fantastic. So, since my audience now knows that you are partially responsible for the reason I exist today doing pediatric pain,
That's
so good or bad, you're responsible.
But I would love to take responsibility for your wonderful practice, but I'm not sure I can entirely do that. You are a fantastic practitioner, and you've always been a strong advocate for appropriate pediatric pain management. So, no, I cannot take credit for that.
Well, you gave me all the foundations I had. So the reason I am doing what I'm doing is because I learned from the best.
You're very kind. So currently, as you know, I work at Boston Children's Hospital in the departments of neurology and anesthesia pain management, the pain medicine department. Mm-hmm. And I've always combined those two departments or those two interests since training, because it allows me to be able to offer a number of educational programs and a number of interventions to patients with very chronic and predominantly neuropathic pain. At present, I am seeing a number of headache patients more frequently, but that is also a primary disorder of the pain transmission system in the brain. So it's just an extension. And the reason to combine these two approaches is because in pain management, we often can take the knowledge that we have and allow treatment options that we might not have just in neurology. Be a little bit more invasive if needed, but we also have an expanded rehabilitative and multidisciplinary access for those patients through the Department of Pain Medicine. So it's allowed me to do the things I really want to do, but most importantly, to be able to give the time to the patients that is necessary. Really need great education, time, and a multidisciplinary approach to evaluation and treatment to affect change. The reason I have chosen neuropathic pain is a reason that I think most people go into medicine. I had family members who had neuropathic pain. When I was growing up, my mother suffered with central nervous system sarcoidosis and the sequelae of that. And my sister passed away early after a very challenging bout with cancer pain and primary cancer. And those experiences, like I think is true for a number of practitioners, encouraged me to look at neuropathic pain mechanisms and to become very interested in trying to advance therapeutic options. So I did my undergraduate research in neurotransmitters involved with pain, and then just moved on to do neurology, but always with the plan that I would do some pain management. So when I first started work, I was at Mass General. I completed my neurology training at Massachusetts General Hospital in Boston. And concurrently, I ran a cancer pain program and a chronic pain program at the rehabilitative hospital. And then the decision was made in the administration of Massachusetts General that they thought that the people who were doing pain through neurology should be combined with the people who were doing pain through anesthesia. And I thought that was great. And then I got to train in procedures and be able to increase offerings to a number of patients. So it was really lovely. And then was able to continue that kind of a practice wherever I went.
Right. Yeah. And I remember some of the most unique procedures that I learned as a fellow were with you. I remember the very first, I think we did you did, and I was just a fellow. You did a ketamine infusion via an epidural for one of the patients we had in the ICU. I'm dating myself back in 2002.
Oh, I know. We keep on rediscovering certain treatments that I've known about since the beginning of my training back in the early 80s. And we seem to rediscover things like lidocaine infusions, ketamine infusions, and bring them back to the fore and hopefully understand a little bit more about their pathophysiology as we start using them again. But it's nice to have a broad armamentarium when you're approaching intractable pain.
And I remember a lot of the blocks that we did for the headaches that were also with you. So I totally do recall that you were one of the fewer people who is also neurology trained, as well as were doing interventional procedures and stuff. But you were also just always so thorough with everything, like how you assessed, how you managed, and yet balanced it so well. All these out of the box sort of interventions that you balance so well with the applicability in the situation, as well as the evidence that was or was not available. I just thought like you had a really incredible way of summarizing how you wanted to make that decision. So that has left a pretty deep and wonderful mark in my own practice. So I thank you for doing that. Because
I'm glad to hear that. I mean, I do think the basis of pain management is the nervous system. So one needs to understand that in detail in order to explain really to the patients and then subsequently to offer interventions that are based on what we know about the current structure and chemical function of the pain transmission system. And we're increasingly understanding that. I mean, for me, it's been exciting having grown up with MRI from the days in the 1980s when it took 3 hours to get a routine scan, and we didn't do it lightly, then to be able to do functional neuroimaging with different software packages that allow us to analyze so many aspects of activity in the brain. And now that we have these interventions, it has only shown us that some of our theories or our philosophy about the balance between excitation and inhibition and pain management and modulation is borne out by seeing the absolute connections and the release of transmitters and neural activity and blood flow and even release of chemicals in spectroscopy. And now that we can see that, I think it gives a great credence to what we have always thought to be the case in management of complex and intractable pain, that it is always restoring balance and maintaining improvement in inhibition for our patients and providing kind of a village of options for them to take part in so that we can work on different aspects of the pain transmission system toward the goal, decreased level of pain and increased function. And that still remains the goal. And the blessing that I have to work in anesthesia is that I have a little bit more time with my patients than many practitioners are able to have because of limitations of finances or insurance or just the need, the demands. Because we're a tertiary referral center, then we see patients who have seen other people and we can try to pull together that work, but also spend an enormous time on education. That's really the most important thing I think that we do.
Correct. Yeah, education, we're training the future, right?
And that's what we need to do. I mean, it's all about education.
Yes, indeed.
And practice without it. But neuropathic pain in children, I mean, it has been known.
If I may interrupt for a second, you were talking about along the lines of understanding the nervous system in details. I think it would be wonderful if you can quickly just highlight what's so different about the pediatric nervous system compared to the adults. And then we can jump into the neuropathic pain. Because again, like you said, the foundation is understanding. So if you can just start with that, and then we can jump into the neuropathic pain would be great.
So I think the three main things that are different are, first of all, that these are our patients are developing over the course of our care. And we will see patient problems and pain from infancy to late adolescence. And we ultimately do often follow our patients into early adulthood because, as you know, maturation of some of the inhibitory systems doesn't really occur until age 26. And so every time you approach a patient, you need to understand what developmental mechanisms are present and what neurotransmitters or what neural substrate is present before they're pruned after infancy to work with so that you don't overdose a patient or choose the wrong medication or not really be able to assess them. So the development of the patient guides our assessment and our treatment very specifically. And then there are developmentally appropriate non-pharmacologic treatments that are very helpful. The other thing, just on one of three, is assessment. Specifically, it is very challenging to assess developmentally delayed individuals, nonverbal individuals, and infants. And I'd love to say that we've made enormous progress in our assessment scales, but I think the progress has come that we use them. When I was in early training, I don't think that people immediately thought of obtaining assessment in an infant, even though the biobehavioral scales and the physiologic scales and the observational scales are imperfect. They weren't used regularly. And now I do think increasingly there is use of a number of developmentally appropriate scales. across the spectrum of these patient populations. The last issue that kind of differentiates the pediatric population is an unfortunate one, which is research. We have limited data on pediatric pain and especially pediatric neuropathic pain. And I was just looking at the most recent reviews and meta-analyses of trials that we have to date, looking at treatment modalities for neuropathic pain, but we really don't have great data because in pediatrics, number one can't do controlled trials easily as the ethics preclude that we wouldn't deny a pediatric vulnerable patient a medication or an intervention that might possibly be effective, even though we don't know it's the gold standard. But we're still limited in that. And also that the numbers that present with these problems are lower than in the adult population. So you end up, in order to understand appropriately, combining across multiple academic and clinical settings a number of patients to come to a true statistically appropriate decision. I do think we're improving in terms of research, but that still remains a major disadvantage in pediatric pain. I hope that everyone's contributing, to pediatric research, but that is a challenge. So the challenges are assessment, the developmental stages that change, and the availability of data to use to make an informed decision.
Right. So, what is unique about the neuropathic pain? Who gets neuropathic pain amongst children?
Well,
What kinds of neuropathic pain do we get in children?
probably everyone and in all developmental stages, but it's, of course, very challenging to assess in early life. It doesn't mean you can't try. And in a patient that is somewhat cooperative, even 4, 5, 6, you can do sensory examinations to determine neuropathic pain. Neuropathic pain has been defined over the years in different ways. And the most specific definition right now is that it is pain that is due to a disease of the nervous system, like a neurometabolic disease, Fabry, or a lesion of the nervous system, like a trauma or a chemotherapeutic injury to a peripheral nerve. Now, that doesn't really speak to the entire spectrum that we consider to be under the greater umbrella of neuropathic pain, especially in pediatrics. There are some neuropathic pain problems that are defined not specifically as a lesion or a disease, but as neurologic dysfunction. And those disorders are the more challenging ones to define for us, like complex regional pain syndrome, functional neurologic or somatoform disorders, functional abdominal pain. Very common if you're running a pediatric pain program, but a challenge to sort out. That kind of a neuropathic pain implies that there was some precipitating factor at some point that made aberrant communication in the nervous system that is now maintained as a sensitivity within the nervous system, in the spinal cord, in the brain, and that maintains a pain independent of any additional injury. So that still is within the understanding of neuropathic pain. So in pediatrics, the prevalence numbers are all over the place because, again, we just don't have that data. But in general, for a lot of nerve-related pain problems, limb pain, injury to nerves in the viscera, even maybe headache, central processing pain problem, these sorts of problems, they range up to 30% of patients that come into the clinic. It is not trivial. It is true that when you see reports of these issues, that it ranges, it's a broad range. It might be from 14% up to 50%. And of course, we know most of our information from the cancer pain population that have had initial or even late neuropathic conditions related to treatment, mostly chemotherapeutic agents that affect so much of the nervous system that radiation, even biologics, not so much the intervention of removing a solid tumor, although certain things like patients who have neurofibromatosis or neuroblastoma will have compression of nerves from a severe mass. But in general, it's treatment related. And so we probably receive most of our information from that patient population. Another patient population that has pain in pediatrics, but not a lot of neuropathic pain, are the sicklers. So sickle cell disease is very prevalent, and we certainly have numbers of patients, but mostly it's a somatic pain. It's more of an acute and inflammatory pain, and might have some components of neuropathic pain if there's chronic activity in the joints, but generally is somatic. And those are probably the most common pain problems in pediatrics in general. But then when you're looking at a patient clinic, you will see limb pain, you will see functional abdominal pain, you will see headache or post-surgical pain. And the other kind of caveat to suggest is that, we tend to be very cyclical in our approach to pain. And the reason I bring that up is that when I was in training, it was the beginning of understanding opioid receptors and opioid availability. And there was a great push to treat everything with opioids and to have pain-free zones for children. Because, of course, children should be our primary concern for eliminating pain. And that was not a perfect approach. One, we seem to sometimes use opioids inappropriately and overuse, and we did spearhead, in part due to not understanding the pathophysiology of where opioids worked and how they interacted with the nervous system. We ended up with overuse symptoms and misuse symptoms and addiction, and we're still trying to work our way back from that. But it doesn't mean that we abandon our need to understand pain, to make it visible, and to ultimately find the appropriate treatments.
Absolutely. Well, that was a great overview that you gave about the neuropathic pain. Where do you think the phenomena of central sensitization falls in this spectrum or in this spectrum?
So I think every nerve injury has a period of central sensitization. And why would I say that? Well, now again, because we can look at the black box of the head and somewhat of the brain stem and spinal cord with very focused imaging, you see changes that occur in the balance of pain, excitation, and inhibition with an ankle sprain. So if you sprain your ankle, there will be changes in the peripheral nerves that receive the inflammatory information, that carry that information to the dorsal horn of the spinal cord, that then transmit that information to the brainstem, thalamus, and higher centers, and that trigger modulation of pain. And in most patients, favorably, the modulatory systems do get activated and quiet down the input that is coming from the periphery. There are times when the central mechanisms don't do their job entirely. And maybe in part, that is related to a genetic predisposition. There is increasing evidence, but very limited evidence, of some genetic alleles that may be associated with the hypersensitivity to pain, such as pain following surgery. Some of the channelopathies are associated with that. And there is association between an opioid mu receptor gene and a hypersensitivity to pain. So there's probably going to be, like everything, a multifactorial reason that certain patients go on to have prolonged nerve-related pain that is associated with ongoing activation of pain transmission systems. And that's what sensitization is. It's when the activation becomes independent of the trigger.
So if I may clarify this, there are predisposing factors, which could be genetic or environmental or however that may be.
Or a number of injuries that ultimately create an allostatic loading to the central nervous system.
So those are some of the factors that would determine as to what the outcome of a person's injury would be. So we may have a child with ankle sprain who just gets over it and is fine, whereas another one who will come to us in complex regional pain syndrome.
Correct. And we all know, as of the past 20 years, that even though the pathology of chronic inflammatory appearing limb pain in complex regional pain syndrome appears to be in the peripheral limb, the primary generator is the brain. And unless you address the processing in the brain, which is why we have multidisciplinary approaches to enhance inhibitory mechanisms, you will not fix the peripheral problem. So you certainly would not fix the peripheral problem by removing it.
So, what are some of the most common neuropathic pain conditions we see in children, or that you see in
So
children?
interestingly, we don't see what is most common in adults. Very common problems in adults are neuropathies, large and some small fiber neuropathies associated less frequently with hereditary or toxic exposures and more frequently with diabetes. There are certain diabetes is not an uncommon medical problem, and many adult patients will have some sort of neuropathic presentation. We don't see that until children usually get into late adolescence. However, if you look at a type 1 diabetic patient using quantitative sensory testing to tease out specific small fiber function, hyperalgesia, sensitivity to cold or to heat, summation, if you do something very specific in an experimental setting, you will see the form FRUST, small fiber neuralgia, but they will not have clinical report of neuropathic pain. So it is there, but we don't see that commonly in pediatric patients. We don't see post-herpetic neuralgia, in part because it's primarily a disorder of older individuals. But pediatric patients, especially cancer patients, they get herpetic activation in areas that they've had irradiation very commonly. Yet they do not go on to have post-herpetic neuralgia. We have babies that are delivered pulling their arms in an inappropriate fashion that should have brachial plexus traction injuries that are fairly common in occupational medicine in adults. And yet they do not go on to have ongoing neuropathic pain in the limb, unless they require an intensive surgery, and then that seems to be an added injury.
Mm.
So what do we see? We see patients who have been treated for cancer and have the sequelae of that treatment. We see patients who have had surgery or multiple surgeries. Let's say that they've required a number of revisions for an orthopedic surgery, or they've had a cancer in the limb that has been removed, but it required extensive surgery. We see that kind of limb pain. But we also see post-traumatic limb pain without any malignancy associated with it. And those patients are the most sort of interesting ones to think about. Why is it that their threshold is lower, or their inability to block that pain signal is just not there? Because when we did look at the ankle sprain patient population, everyone activated up to the brain, and everyone released inflammatory substances, and everyone upregulated a genetic profile that's associated with cytokine release. Everyone did, but only very few went on to have chronic pain. So we're all searching for that sort of magic biomarker
Mm-hmm.
allow us to predict and therefore treat aggressively or not do interventions that aren't necessary, surgeries that aren't necessary on individuals who are susceptible. There is, of course, always a cultural, sociologic, psychological component. And clearly there have been studies that trauma early on reduces the ability of the nervous system to block pain. So if a patient, a young child, has been exposed to peer trauma or family trauma or early on, they are susceptible. If there are family members who have chronic pain and also a lot of fear regarding pain, there's an increased catastrophization regarding what the meaning is of the pain. And work on fear, because those particular areas of the brain that produce fear of pain also can link to activity elsewhere in the brain and reduce your tolerance of pain. And that is what we see with functional neurologic disorders and imaging. So that very interesting group of patients who do not have a significant injury, although they might have had a minor trauma, and go on to have paralysis of a limb or blindness or seizure-like activity or a motoric shaking activity of unclear etiology that is resistant to a number of medication offerings. They clearly do have disinhibition of connectivity between those fear areas of the brain and the memory of pain, the hippocampus, and their motor cortices. And they have nothing to block it.
Interesting.
So when you're looking for the top-down influences on pain, they don't have that. They need to develop that system in order to prevent them from having a disinhibition of these neurologic features. So it's a very real disorder, and at the level of the brain, like all neuropathic pain is, though it might look to be more peripheral.
So, Dr. LaBelle, a couple of questions actually in my mind right now. One of them is when a child is born with a, say, brachial plexus injury, like shoulder dystocia or whatever, why do you think they do not develop?
Because I think their population of neuronal inhibition is a different balance than for the adult. And we know this from early studies looking in infancy at the population of inhibitory neurotransmitters versus excitatory neurotransmitters, the level of the dorsal horn. We can see also that they don't make the connections immediately to the thalamus or to even higher centers of appreciation. And so it might be that they have an experience of some pain. This is always challenging to see in infants, but I'm sure they have sensation. But the experience is varied by the development of modulatory systems in the brain. And there are different populations that then change over time.
Right.
And that's why when you use medications in these younger populations, you have to adjust your doses for many reasons, but also because there are parts of the nervous system that are more immature. There are parts that just don't have as much excitatory neurotransmitter release. There's a different balance. So if you overload the system, lots and lots of procedures in infancy, you can probably lower the threshold ultimately for development of neuropathic pain. It's variable. That's not true across the board, but that's why we work so diligently to block pain in a neonate that has to come back and forth like our esophageal atresia patients and have multiple surgeries and multiple procedures done. We want to make sure, because we don't know in the infancy of some of these very intensive surgical interventions that require a lot of neonatal work and infancy work, that they won't go on to have long-standing changes that wouldn't be apparent until late adolescence.
Well, that's making me think about the kids with colic. There's been obviously evidence, research suggests that kids who have more colic early on are
Right. It's a tough call with the headaches, with migraine, to say that if you have infantile colic, that might be the first manifestation of headache. There's some support for that in the review of the literature, that true colic, not just some feeding irritability, but truly hours during the day repetitively, that many of those patients seem to have a higher likelihood of transforming into a migraine patient in later life. And we do know developmentally that there are different parts of the brain that are active with the same stimuli that might produce a classic migraine. Adolescent will produce torticollis in a younger child, or produce vertigo, or produce colic, abdominal migraine, just abdominal pain. So there are different presentations in earlier life, and that has to do with the development in the pain transmission system.
Right.
Once you get to the adult phenotype, you're going to see more. When you get into adolescence, you're going to see more classic and common migraines.
Right. And then there's also evidence with colic being there resulting in higher incidence of functional abdominal pain.
Yes, there's that as well. So why do certain visceral afferents get activated with colic for a prolonged fashion and some do not? So that again will come into play. Is there a genetic predisposition? I do think we're going to have to look at genetic predispositions. It's just tough to study. You need large numbers. And right now, we only know of a certain number, a very small number of genes that seem to be associated with pain modulation,
Right.
like the catechol O-methyltransferase and some of the opioid receptors.
Is there a way to prevent? We're looking at one of the way to obviously intervene is stop the repeated stimuli that we're having. But is there a way to prevent this triggering of the central or peripheral nervous system, which ends up in
Well,
neuropathy?
that's a very important question, because then we should be applying those measures with every intervention, every surgical intervention. And I think it has become clear in the perioperative field that multimodality approaches to surgical procedures that might have nerve inflammation, like scoliosis surgery, they should have multiple interventions, not just a dose of OxyContin and a nonsteroidal. They should have also neuropathic pain medication, but they also should have earlier movement of the nervous system so that there isn't an ongoing barrage of just inflammation from immobility. So there is definitely an appropriate multimodality approach to perioperative pain and kind of a de-emphasis on the classic opioid management. And I think that is a good thing. Opioids have their part, and they are fascinating substances. And as we release and we get to know them better, maybe we'll be able to find those that are free of tolerance and addiction or adverse effects. But anyway, yeah, I think that we're doing a little bit better in terms of the multimodality approach to try to dampen ongoing inflammation and ongoing agitation. It is an inflammatory model, I think, for chronic pain. Not so much that we're just releasing cytokines or creating a peripheral inflammatory response, but that we're also altering the communication between the supportive cells, the glial cells, the astrocytes, that help the neurons function. And we're changing the ability of those cells to quiet down and activate the nervous cells. So there's a neuromodulation at a very microscopic level that probably is percolating or reverberating at a low level in patients when you can't see any acute inflammation or fever.
So when should we be, obviously I'm thinking about practical applicability in some of our, especially our primary care physicians and our
So one of the first things is recognizing it. I do think we're doing better in recognizing neuropathic pain. I must admit, sometimes our orthopedic surgeons overcall it, but I'm very grateful to see it because on the radar. So that is what we first have to do, even if it's not really, going to go on to be a significant problem for this patient. If you recognize that it might exist, that is probably the best thing to do initially. And then to call it out, to refer to someone who might have more expertise. It might be in neurology, it might be in pain management, to review the case. But how do you recognize it? So we're stuck again with patients who might be nonverbal, and we can get caretaker information, which is often very good in terms of different aspects of pain expression. But as soon as patients can localize and can communicate and eventually rate their level of pain, even on very basic scales, we can get that information. So young children can provide it. Young children are not malingers. If we're testing them and we see findings on the sensory exam that correlate with neuropathic pain, that's very real. So if you elicit allodynia, if you elicit summation, if you elicit hyperalgesia to stimuli, light, touch, temperature, repetitive stimulation, mechanical stimulation, that is real. Or if patients have a mixture of negative and positive symptoms, they say, I've got pins and needles, but it's numb. If you provide that information, and what I always found extremely helpful in early practice was to have patients draw. So pediatric patients can draw neuropathic pain. They will show it as sharp and stabbing, and it is very amazingly expressive. So you can elicit it in a young child, but you have to have awareness about it. And you also need to know that there are certain injuries that may more likely be associated with a nerve injury. But you have to just have an open mind to look at those superficial sensory testing and the report of the patient as a descriptor of the pain: electrical, burning, sharp, stabbing, tingling. All of those things can be elicited in primary care. Unfortunately, in primary care, you don't have a lot of time.
Mhm.
But if you have a lower threshold to recognize it, you can bring them back and you can refer and you can start to educate and make it visible to the parental support. If you make it visible, even though it might be an overcall eventually, the family will then say, oh, yes, they've been doing this. And that will help guide what you do next. We're not there yet in understanding all pathophysiologic changes that explain all pain presentations. We're getting a little better, but still pretty far off. And we definitely don't have the gold standard of treatment.
Right. Well, one of the things, even when kids don't have the language, they are able to absolutely express. And a quick example, a story I'll share with you. I took care of this kid with 4 years old, erythromelalgia. And as I was discovering how long it's been going on, blah, 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 the parents said, I think it's been going on longer than we know, because when he was about a year and a half old, maybe, I mean, there were things that he was doing, like he didn't want to have footy pajamas and things like that they could think back to.
Right.
At that time, didn't think about it, but now they could. Like about a year and a half, 2 years of age, he would say, my feet feel wally wally. And what is wally wally? And then they said, one day we had a computer or like a TV screen that had total static. And he says, wally wally, wally wally. So that was amazing to me that this kid didn't have the full language spectrum, but he could describe.
Yes, and they can act it out as well. I mean, children have many ways of expressing themselves, so it just has to be encouraged. And it is very important to partner with the family because they're with the child all the time. And if you provide that education or what to look for, I think you'll get a lot of data.
Absolutely. So, Dr. LaBelle, would you say sometimes with this increasing evidence that's coming out that there are triggers, that repeated injury or repeated triggers for activation of the nervous system, be it chronic constipation, be it the colic, or we have got the athletes and gymnasts and things like that, repetitive injuries. When should the primary care physicians or the first liners think about aggressively managing that versus saying, well, it's constipation, we'll just take care of it? And
right. If they can see that there might be some associations, and one of the greatest associations is a lower threshold within the autonomic nervous system. If you start to see that happen in the setting of chronic constipation or in the setting of limb pain, and what does that mean? It means that they're going to have a number of symptoms referable to autonomic overactivity, sympathetic tone. They might be lightheaded. They might have large but nicely reactive pupils. They might get temperature and color changes in their face and hands and feet. They might get clamminess. They might have, if they didn't have bowel things before, they might be at more risk for constipation or other bowel hypomotility. If you start to see that this is looking like a more diffuse neurologic issue, or that's the beginning of sensitization, that should be addressed. So it's hard always to make the decision with an elite athlete of taking them out of their sport, but there should, at least should be education and discussion of coping strategies and rescue interventions that one needs to know.
And what can we do for the neuropathic pain? I know we're not there yet, but what are the
Well,
most effective
we
ways to address?
desensitize the sensory nervous system. So we distract, we condition. So patients who have a sensitivity in a limb might try gentle rubbing. You use TENS units, you use topical agents, you use lidocaine. Then we make sure that they don't restrict the movement of limbs or restrict their overall function more than absolutely has to be, because that clearly leads down the path of central sensitization. So we immediately do that. There are a number of medications to try, but most of them come from adult data. We don't have great trials. And really, we don't have too much to say that the non pharmacologic interventions, especially the cognitive exercises, are not 10 times better than trying gabapentin. So we should not forget that we need to work on behavior and cognition early on. And we have to teach the ability of the individual not to fear. And that needs to come with the parental units. Because if there is a response to an expression of pain that is fairly intense, that will quickly become part of the hippocampal memory of these patients, and they will quickly trigger a severe pain response. So we need to work on fear, coping, rescue. And then some medications are helpful. Some injections and interventions that are a little bit more invasive are ways to allow the patient to be able to manage their own pain more effectively with other modalities. So there's a lot we can do. The problem is there's not that one magic intervention that will turn the switch off to central sensitization.
And the other thing is we just need to give it the time, and we need to have that patience for all those to come together and work.
That's right. And you need to very much educate, and you need to desensitize the family a little bit to the nature of this. You need to know that you be confident in your approach and say, we see this, we know what this is. This isn't that we're missing something. This is the nervous system. It's not suddenly a new tumor. It's not suddenly a new infection. And we also have this enormous history and experience in using a multidisciplinary approach, which you should not be prevented from experiencing. It doesn't mean that we won't keep an open mind and use medications as needed and interventions as needed, but you really need to present it as we do understand a fair amount about this nervous system. I wish we understood enough to rewire, but I don't think that that's an easy intervention.
What would be your bottom line or a summary statement for healthcare professionals who may encounter these pain?
Well, I just say recognize early. And if there's any concern that there is a neuropathic pain, look at the whole individual. Look to see if there are other indications that the autonomic nervous system isn't quite right. Has there been a history of repetitive injury? Now, these are things that would bring this patient to maybe the next step in evaluation, and then working between primary care and a pain management individual to be able to prevent this patient from going on to having significant disability. That's always the goal. I think recognizing number one, and number two, offering interventions that are non-pharmacologic off the bat. The distraction techniques, the supportive techniques, the cognitive techniques. But that's not trivial. Those clearly have more data than any medication. And if you look in the Cochrane databases, that's where you'll find that data. And it is very robust. Do we use medications? Sure. But all medications have side effects, so we just need to balance their efficacy.
Well, Dr. LaBelle, thank you so much for taking the time. I know you have to leave. I will include your contact information in the show notes as well. Thank you so much for taking the time.
Thank you so much for asking. I'm very lucky to have worked with you and to have an ongoing collaboration.
Thank you. It's all my pleasure and honor. Thank you. Thank you so much. Have a great day.
You too.
There you have it, folks. What a wonderful step-by-step breakdown of what's unique about children's neuropathic pain. What are the different challenges that are posed when we encounter children's pain or nerve-related pain? How to go about addressing those challenges? And finally, despite all those challenges, there are still several wonderful ways to address these very effectively. I hope she has given you enough to base your practice on and feel confident in treating these very difficult pain syndromes in pediatric patients. And folks, if you enjoyed this episode, make sure you share it with somebody else who might be looking for these very useful pearls of wisdom. So share the wealth. Also, let us know if there are other topics that you want to hear about and if you have any specific questions. I would love to be able to address that myself and or with another fantastic speaker like this. Make sure you subscribe to our podcast if you haven't already and give us a review so that this can get into circulation, get to more people who need this information, who need to know how to deal with these challenging situations just as much as you and I. So I am counting on you. And of course, we'll be grateful for you to share this with others. Next week, we're going to have another fantastic speaker, Dr. Christopher Eccleston from UK, of the famous BATH questionnaire that he has created and that many of us in chronic pain use. He has been a leader not just in the psychological interventions for pain management, but how to appropriately address pediatric pain care. I'm discussing one of the most recent commissions that they wrote for the Lancet Child and Adolescent Health. And I hope you will join me because there's so much more than just that article. And the conversation was fantastic. And you're going to love his storytelling way of giving you amazing amount of information. So join me next week. In the meantime, be safe, be proactive. Bye now. Pedia Pain Focus is brought to you by Proactive Pain Solutions, a company committed to improving the lives of both the children affected by pain and the clinicians who are taking care of these children. Through our online education and consultation for clinicians and the institutions, we're transforming pediatric pain medicine through improved access, quality, and expertise. We're creating experts and leaders in the field, empowering patients and caregivers with knowledge and tools for self-management that enables them to live a fully functional life. If you wish to advance your pain care expertise or improve the operational performance of your pain care services at your institution, or you simply want your patients and families to be more informed and active partners in their own care, contact us at www.proactivepainsolutions.com and set up a free consultation today.